And then I think I just want to say off the bat, I don't think any standing kind of, what I'm going to share today, I've learned from a book necessarily. Obviously, there is research on standing, and there's a lot of guidance out there. But I think the most valuable thing that I've learned about standing is actually working with children and their families and real life problem solving when you really don't necessarily have the kind of equipment that you can see on nice pictures on the internet. And I want us to not get stuck on equipment or what we don't have, but to really look at the principles of standing and how we can just make it a part of one of the things that we can use to help children with CP or similar conditions and to help their families, and how we've heard now from Sarah as well to prevent and what we heard from Jillian earlier today, help prevent really bad deformities or pain or contractures happening. Right, so let's go over. I'm going to share. Let's just get that ready. Cool. Alrighty, so I wanted to start off by just putting this question out there. I think it's very obvious, and it's included in the title of our webinar. But I think when we see children who are level 4 and 5 on the GMFCS, we don't necessarily think of standing off the bat. Or if you're like me, I would think, it's going to be really difficult to get them up even further against gravity. And that there's a lot of gravity is fighting against this body, and it makes it quite hard to get them in a different position. And we tend to see them more often in lying or sitting. So I just wanted us to, off the bat, just put standing in our 24-hour postural care mindset, that standing works alongside lying and sitting. And I'm sure, as we all know, standing can give us such amazing benefits, and we'll look at those in more detail as we go along. But the crucial thing, and the thing that there's most research on, is that it provides, that weight bearing provides, something that can protect the body and the body shape and protect the hips. Now, there's lots of research on how much and in what position exactly you would get the most, benefits out of for bone density and so on. And I think it's not always practically possible, especially in a low resource setting. But I think when we are introducing the concept of standing to a caregiver or to a family, that we need to also involve them in this concept that standing is actually very beneficial. And it's not just that we want the child to have another position, but that standing actually promotes a lot of good physiological functions and bone density and digestion and all these things that we'll look at. And then the other thing to note about standing is that unlike sitting or lying, it's not actually passive. It is an active activity. You are actively engaging muscles. And I think especially for children on a level 4 and 5, that is so crucial, that we can involve them even more and help them, get them to participate even more, as it's often they've got a lot of things that are getting done to them. And then, as I think Jillian and Sarah have mentioned already, is that just understanding how to work with a family or a caregiver to make standing part of a daily routine, rather than having it be another thing that they have to do. So just a little bit of an intro of what we're going to unpack in more detail as we go along. Right, so I wanted to put this in, so the who, why, and the where of standing, because I think it's important when we explain to a family or a parent or caregiver why we are introducing this concept, or to have this kind of discussion with them, to not just jump standing on them. So sometimes I think there's a misconception that some CP subtypes are a bit too difficult to get them to stand, especially kids who are extremely floppy and you are just fighting gravity, or if they are extremely stiff and you can't get them in a straight enough position to call it standing. Or just those dystonic children who push too much, that we cannot get them to relax into a position. And then we would probably sometimes even not attempt it. But I want to encourage you that standing is for everyone, and all CP subtypes can stand. And we are today especially talking about the level 4 and 5 child. So it's really about using our principles that Gillian shared in the beginning of what this body needs. How can we use that to help them stand more effectively? So the other thing of who should stand, it's not someone with good head control or who can take some weight on their legs, or all these requirements that are needed for someone to be able to stand. But actually, if we look at typical development and we let us that guide us of who needs to stand, we want to get a child already around the age of 9 to 12 months to start doing standing with them. Because that's when typically developing children start pulling to stand or standing for longer periods when they stand supported at a surface. That does not mean we need to follow typical development, having certain things in place before we get to standing, like I mentioned, head control as an example. But one very big reason why we want to stand is we want to preserve those hips, and we want to get weight bearing so that we can form those hips, so that we don't have hips that are dislocating and are in pain later on. So we need to start early. Does that mean when we have an older child that we've missed the boat? No, not necessarily, just as Sarah said. So let's look at why. So some of you might know these benefits already, but I do think it's important to share that with this concept with a family, that we're not just standing to get someone in a different position. We're not just standing to stretch them. We're not just standing to add another exercise to the repertoire of what we need to do. But it's got quite a few benefits. So as I've mentioned already a few times, it increases bone density. When we look at the hip integrity, why we get so many dislocated hips are because of non-weight bearing children, and that the acetabulum or the hip joint becomes very shallow, and then and the muscles that support that hip joint are never used, and then that hip dislocates easily. So getting them into a standing position can help protect their hip integrity. Like we saw that child that Gillian started off with, and that's the child on the flyer, just looking at that position and what the beginning part of that position was when the child was young, to where we look at them when they were a teenager, how their contractures have increased, or their flexion in their legs have increased. So obviously, if we get someone in standing and we get more extension, we are helping to look at the contractures, especially at hips and knees and ankles. And think about the positions that a level 4 and child usually are in. They are in a sitting or a lying position, and not even talking about a good aligned in one of those positions, but they do have a lot of flexion throughout their day, which makes standing so useful that we can have a different kind of position for them. It can also influence tone. So with standing comes weight bearing, and weight bearing can be quite relaxing for stiff muscles, as we know. So we can also have the other benefit of if you're a child, if you have a child who's very floppy, if you bring them up against gravity, you obviously increase that tone. You're asking that body to work a little bit harder. So for different reasons, standing can be quite beneficial for a child like that. Then obviously digestion and bowel management, because we are letting gravity help us. So being in an upright position, we know that standing, research shows that standing positively influences that function. And then, like I think Sarah mentioned, maybe a speech therapist would think, oh, the lying, the positioning, what does that have to do with me? And I think it can be said the same for standing. I don't think standing belongs to anyone specifically, especially if you're a therapist working with kids with CP. We all have our things that we know more of if we think about therapist boxes. But just thinking of principles and what the body is doing in front of you, how can we help this body? And breathing and voice control is one of the ways we can do that in standing. Again, it's activating that trunk, it's activating breathing, because you're in a different position. You've got more space to breathe. So yeah, it is not just for a one's therapist specific person to manage that, but also helping a caregiver understand that we can engage in this way. We can get more participation from a child in this position. So just mentioning that. And then social engagement, being it with the family or with other children, depending on the method of standing. Here on this picture, kids are standing in standing frames. That's not necessarily the only way that they can get that benefit, but just being upright and not on the floor on a chair, but being part of the family at the same height as their peers or as their mom, just having a better place for engagement. And then a huge amount of sensory benefits as well. So if you are so used to lying and sitting, then just being upright must feel very weird. But just also getting that a different sensory feeling, but also training your body and your vestibular system, your proprioceptive system in a different way. Your body will have more feedback, and probably you will learn more control in that way. And the other thing is just thinking about the position if someone is only sitting and lying, is their visual system, and what angle are you always looking at? And as we know that kids with CP, it's very common for them to have visual difficulties, especially CVI. So standing can have a huge benefit for what level, what quadrant you are able to access with your eyes. So just some of the things that can be discussed with a caregiver or with colleagues, of why we are even thinking about standing for a child who it's very difficult to stand with. There's you can go on the internet for this is just the first thing that I found, actually, that's quite nice, with pictures that explains. And I think somewhere I saw when you were registering, there was a question about if you have a language barrier, or how can we communicate these things to caregivers. So I think using pictures like this with a basic translation would be quite a good way to approach that. Cool. Right, let's look at where can we stand. So we've also heard from both Gillian and Sarah that posture care is dynamic. It's not just one thing. It's not just plopping someone in a chair or in a stander. They all the positions and all the efforts that we are trying to do are working together to protect the body and to protect long-term quality of life. And like we've also hammered before, it's not meant to be another thing that someone has to do, another tick box that someone has to get through. I think the buy-in with a caregiver, if you approach it like that, will be very low. But yeah, helping someone see or chatting through it, how we can make it part of daily life, and just thinking of the things that they are already doing and can they do it in a little bit of a different way without breaking their back or it being too difficult. So can we look at dressing? It happens a few times in the day. Is there a time or a time in the day where dressing is not rushed? So not talking about when someone needs to rush to the hospital for an appointment or going to church or when they really don't have time. But can there be a designated time where we try something? So say before we go dress on the bed, we can stand and in supported standing, like holding on to them, the sort of weight bearing on their legs, we can then pull the pants down and then go to the bed. So something simple like just introducing a little bit of that, not necessarily standing for the whole dressing or standing for a whole hour just to get dressed. That's not what I mean. I think just discussing with parents how and when we can implement this. If they're already going from the bed to the chair, can we talk about them having a bit of a transfer, a standing transfer? And we'll look at that with some photos a bit later. They're already probably playing with their child, or is this a concept we can maybe show a teacher at school, whatever the setting might be where this child is at? Can we, rather than sitting on the floor, maybe one of the times that we are playing, can it be in standing? And we'll look at how we can stand with different options, with equipment and without, etc. So just to look at what is recommended from research. So we want children to stand for 3 to 5 times a week for 30 to 60 minutes a day. And that's the guideline. It does not mean when we start standing with someone, doesn't matter their age, that we will just jump to an hour a day, especially with someone who has not stood before. So they have to build up to this amount. And like Sarah also mentioned now towards the end with the lying, supported lying, we are going to let the child guide us. We are going to let the caregiver's capacity guide us. But I think if we start implementing it as part of the routine, we are building it up slowly, and we are introducing it slowly, and it's not necessarily just here's something to stand with and you have to do this. And you'll probably see better buy-in. Cool. Right, just checking my time here. Okay. So when can someone not stand? I know I said it's for everyone, but it's not all animals are equal. So there's definitely certain things to make sure of. And if you are not sure, I'm sure a child would also complain of pain, which is quite an easy way to know if something is up. So we don't want to stand someone who is unsafe to do any weight bearing. So if there's any fractures or osteoporosis or something, if they have severe contractures, so we might build up to standing, we might do a bit more of loosening and see how far we can get. And you would know your client and depending how long you work with them and what has been tried before. We don't want to force someone into a position where you are tearing their skin and it's uncomfortable and it's painful and So definitely not that. I'm not talking about mild flexion contractures. If we can make a change with how Gillian has mentioned, loosening a stiff child, if we can get some change in that, then I would say it's safe to stand them. And we're not going to force a completely upright position. We'll look at how we can accommodate for some contractures. Then dislocated hips. So there's a lot of talk about that. So to not stand with a dislocated hip. So we don't want to make something worse, but the hip is already out. So if it's asymptomatic and there's no pain, then I don't see why it's an issue to stand. We just don't want to create a new problem higher up and just looking at alignment. But yeah, if you've got some subluxation but there's no pain, then it would be good to stand. And then if a child has systemic distress, so if there is a drop in blood pressure or difficulty breathing, that is something that you'll quickly see when you bring them upright, and just something to make sure of. And then remember what we said in the beginning is that standing, we are fighting gravity. So if someone already has a severe scoliosis, it can make them standing safely quite difficult. And we'll look at a little bit what we can do to get the benefits of standing without standing completely. But we don't want someone to stand for the sake of then, like Sarah was mentioning, the life box completely being just affected negatively. So just having a look at that. Cool. Right, so we're going to look at different ways to stand. So first we're going to look at standing with equipment, and then with limited equipment, and then without equipment. So if we are looking at equipment, there are three different kinds of standing frames that we can look at. So firstly, an upright stander. So the middle and the left picture are Sukumani Dream standing frame, so just a box frame with some pillows inside. And then on your right, you've got the Timion frame that works on the same principle. It just operates a bit differently. So who can stand upright? We want someone with enough hip range of motion to be able to get into an upright position. So we don't want to, like I said, force someone with a severe contracture into this standing frame. What is nice about the Timion frame is you can actually see in from the sides and you can see exactly what the hips are doing. With the box frame, you can sort of peek in from the top, and you should also be able to see by just looking at the feet. Yeah, you'll be able to see what the body is doing inside. So for upright standing, we want someone with a little bit of head control at least. You'll see that these kids have some support at their head. It's not that they keep their head upright by themselves, but it's not an effort for them to stand upright when they have this support. You'll also see that the middle and the left picture, the tray table is tilted slightly. So that's also just assisting with keeping their head a little bit more upright and helping them not work so hard to keep their head upright. But we want to be able to, we want to put someone in who has the range of motion in an upright frame, if they can manage it. Okay. Right. So, and then a prone stander. So usually with equipment wise, prone is a more expensive kind of equipment. You'll see the fancy one. But I just want us to look at the principle of standing in prone, and who would we want to try and get into prone standing. So firstly, it works really well for kids who were born prematurely. Sarah also mentioned that kids who are premature struggle with being in supine, and that they use some weight on the pelvis and vibration to relax them and help them feel safe in that position. So kids who are prematurely born usually enjoy having that support from the front. So rather than being upright and almost feeling that there's space between me and the earth, the prone seems to help with that. I also like it for kids who are dystonic. For some it works, for some it doesn't. Some just push more, so it would need to be a test. But because in prone there's a little bit more opportunity to bring in an element of flexion or breaking that pattern, as Gillian mentioned in the beginning, having a wedge or something on the tray table where one hand is doing something different, so just breaking that pattern. The same, I think, I feel like you can do that easier when they are in prone. And if you have it at the right height, you can get quite a nice flexed arm, weight bearing through the elbows. And it also draws, especially if they're doing something on the table, it draws their head in a little bit more of a flexed position, which also helps for a dystonic child. Then the other child that would benefit from prone is someone with not great feet, whose feet are already contractured. Just being in prone is almost, just offloading a little bit of the weight, not putting their full weight on their feet. Or someone with a little bit of pain or limited hip extension, if they can't get all the way to upright, we can support them a little bit better in prone. So if their hips don't come all the way down flat, we can add some cushioning and get them as stretched as possible, which is a bit more difficult to do in an upright stander. And it doesn't have to be fancy equipment. It can be a plank or a APT kind of board, and finding a way to have a bit of a tilt on there. It just has to be safe. But yeah, I think that's what we want to say there. Cool. And then if we look at standing in supine, some of you might know it as a tilt table. For those in South Africa, the Shonaquip one is quite nice because it can be prone or supine. You just change the tray table around. So who would we want to stand in supine? That would be for a child with really limited head control, as you are letting gravity assist you with the head. It's also for kids who struggle with that systemic stress of being all the way upright. You can really grade how much you go upright if you are having a frame that can tilt. Again, you can offload a bit on contractures if you play around with the tilt and not put so much pressure and gravity ask of a body compared to being upright. And then it's easier to get a heavier, bigger child or person or teenager onto a flat surface. So if you tilt the frame all the way horizontal, to then from a lying position, maybe 2 or 3 people, how many you need to get them onto the frame, get them all positioned correctly before you start going up, is just much easier than fighting gravity and getting someone really heavy to go from sitting to standing. You can also check out Timion has a sit to stand, which I didn't put a picture, I just realized now. But I think Daniel will probably show you something along those lines. But yeah, just to make it easier to get someone into a frame. Right. Okay, so we looked at when you have equipment. Now we're going to look at if you have limited equipment. So I know we've mentioned soft splints a few times, and for those who are not familiar with that, it's basically a piece of sponge with a cover over with Velcro. Um, and it's quite easy to recreate even if you don't have these materials. So something like a towel or a blanket with that you tie with string or a sock or a pantyhose or something can also work. Um, but yeah, they work quite well to help you with kids who are more difficult to stand. So here on the left, you'll see this mom is doing a sandwich standing, what we call sandwich standing. So with her front leg on the knees, pushing more on the knees, and her back leg on her bum. Um, and depending on the child, you'll see that this lady has got her foot up on a block just to make it a bit easier. So just thinking about how this caregiver would like to sustain this for a certain amount of time. How long can she do it, and how comfortable can we make her? Do we need to let her sit against the wall? And also, and in this photo, this little girl is using a therapy bench and a block and stuff, and it doesn't have to be that. It can be any table or surface. We are just looking for the right height that can support her. But she does have soft splints on. They're same color as her pants. It's a bit difficult to see, but she's got these same soft splints on, and it just makes it a bit easier to keep her legs a little bit more supported and straight than without it. So what's also nice about a soft splint is that, especially for kids with dystonia, is that circumferential pressure gives them better feedback of where their body is, and you'll actually see that they relax a little bit more. And obviously it gets a bit warmer, so that's quite nice for stiff muscles as well to just relax. So it's quite a nice way to stretch and just make standing easier. So you'll see that the other photo, this mom is just helping this child stand without anything. They are, I think, transferring from one from sitting to another place. But it's always beneficial to have a surface in the front, especially if you'll see with equipment as well. There's always a tray table. I'm not just standing with nothing in front of me. It can feel very scary, but also it just gives more support. And like with this little girl who has an element of dystonia, you can see that she's not completely upright, and that she's bringing in a little bit of a flexor pattern just to help her stand more effectively. Sorry, I'm just gonna, I've got a bit of a frog in my throat. Sorry, apologies. Okay. The other thing that you can use is a keystone splint. So it's very similar to the soft splint, where the soft splint is just soft sponge material or something similar. The keystone splints have a rigid insert. So they come in many forms. I've added at the end of the presentation, there's a link to this homemade one. This is actually just ice cream tub cut up and layered a few times. You can do it with wood or splinting material or APT, cardboard layers or something, just to add a rigid element. You'll see this little guy is standing with keystone splint. So they give a little bit more support than the soft splint because it doesn't give way as much. So yeah, I think it can be quite helpful to add this to someone with a little bit more of a powerful tone. They must just still be comfortable. But yeah, it's a similar concept to this one, just with a bit more rigid support. And then just you need to take in comfort. Yeah, it mustn't hurt them to stand, and you're not going to do it. So just think about where, if it's digging into the skin anywhere or so. So just making that adjustment. Okay. All right. And then the other way we can stand is by building something from APT or the likes. I know Daniel's going to chat a little bit about APT, but I would like to show you a quick APT. So these box frames work quite well for younger children or smaller, lighter children. And you can add as much support as you need to add to them. Um, this pink one has lateral side supports and a strap and a bum strap and some padding, some cushioning for knees. This little guy is only has a strap, so you can really play around and decide how much support this child needs. So I want to show you just to make a shortcut APT. APT is quite a long process. But I made this one with the red tape about 6 months ago, and this little guy is in it every day, and I think he's quite rough, and his two sisters are also playing with him quite rough, and it's still alive. So it is worth it, especially to get in there while they're young. So yeah, just want to show you how you can do that, and hopefully you understand these drawings. Thank you to my expert drawer that did this for me. So number one, you want to find two boxes that are the same height. If you don't, your life is a little bit more difficult. So yeah, try and find boxes that are the same height. And then you're looking for a box that's quite strong, that has these corrugated mesh in the middle, in between the two smooth layers. You don't want a very thin box. So something that's already strong. And what you're basically going to do is you are not cutting away any box. You're actually just folding it onto itself so that it strengthens itself. You're just adding layers. So the size of the box, you would want to look at the size of your child. So if we're looking at a level 4 and 5 child, we would probably want this box to be at nipple height. So you would measure that, and that would be your height for your table. It would depend on the child. If you have a lower box and there's still enough space to add your support, you can always add a wedge or a block or something on top, or as they get older. But you want that to come quite high for a level 4-5 child. Right, so you're going to glue the two bottoms together with wood glue, and then you just need some force to keep it there. I use heavy books, or you get these nice clamps that you would use in woodwork, or you get someone to help you. But as you saw, I resorted to duct tape. I wanted to be quick, so I put a book on and then put duct tape so that it stays there. So it's not the most beautiful thing, but it works. So you glue the two ends, and then you would fold in on the one side so that you are creating a nice thick stable surface, and you would glue that. And then the thing that really makes this nice and strong is to score, so meaning not cut all the way through on the green line, and that part you are going to fold back over itself, and then whatever is sticking over, you score again and you glue it again. So then you've got quite a nice thick stable box, and you can see it already looks like the standing frame. So with each process, I would just make sure that the glue dries nicely on that side, or at least dries enough for sticking. before doing the next bit. That's the only, can't be too rushed, but it doesn't take days to make. It takes 2 hours or so. And then you can play around with what your holes look like. So this is how I made it for the little boy in the photo. I just cut one big open hole for the feet. You can cut two holes like you'll see the pink one has, if it's someone who you want the feet a little bit more stable and using the box to align their feet a bit better. I just made it like this because I'm not sure how quickly he will grow. So I just wanted to make a quite open foot place. And I couldn't find a box that was small enough and strong enough for this guy. So you'll see that I actually lifted him up so that the frame can grow with him. He only has holes for a strap for his bum because he doesn't need the torso strap, but you can fit both in there if you've got the right height box for your child. So you'll make 4 or 2 holes depending what you need, and you can, to just join the boxes nicely together, glue another piece there between the two, that the two boxes stay nice and tight, and that there's a flat surface for the feet to go through. And then you just add a strap, and the strap doesn't have to be fancy. You can sew it, you can do Velcro, you can do, like I say, a pantyhose or a sock. It just has to be safe because that's what's keeping the child upright. You can't have something that will easily split open. And then obviously just to make sure that whatever is behind this child, that they're not going to get hurt if they accidentally come out of the frame. But you can also see that there's space here to maybe add some pillows or something more rigid if they need more support on the sides, because there is some sides to this box. Yeah. And then especially for children who tend to push back or are quite active and moving a lot, I would just weight it in the front, so you can add bricks or just heavy books or something. And yeah, then you can have a upright frame. So here's this little guy. He does not have CP, he has spina bifida, but we are working on getting nice hip extension. So you'll see here, it's not looking that great, but he can go into that position, which is quite nice that he is actively doing that, and that he can play on his own and he can play with his hands free. And that's what we want for a level 4 or 5 child. Their play might just look a little bit different. And you can see here, his mom just used some books to lift him up. So that's my hope, that the frame will last a little bit longer. And you might need to make new holes for the strap to move down or whatever, but then there is some space for that. You can add sponge if you're worried about the knees getting hurt, but yeah, these little box frames tend to work quite well, and it's quite a nice way of giving someone an opportunity to stand. Cool. All right. Hope you are still all fine. Let's finish this section and then I'll give us a 1-minute break to just shake our heads and do a stretch. So let's look at if you have no equipment. So sandwich standing is really a winner if you can use your own body. The kids in all these photos are quite small. You can, depending on how strong a child is in terms of their flexion or their movement, it can be more difficult to do with a bigger child. But the principle of it is that we are doing the exact same thing as in a standing frame, that we are giving force on the bum and force on the around the knees, and that we are getting the legs to remain straight. So depending on what we are doing, it would be very good, like I mentioned, that there would be something in the front. So if it's for playing, or yeah, having a snack, having something in front of you, a table in front of you. You'll see this little girl. We've added a towel here. She tends to push back a lot with her head, so it's just helping her mom get her head a little bit more forward. So yeah, not really using equipment. This can be any table and any chair or crate or brick. But yeah, the concept of the back leg pushing on the bum and the front leg pushing on the knees works quite well. You can see this guy by the quality of the photo, and you can see the feet that he was moving quite a lot. And after placing a table, there's more opportunity for him to support his body. So it's definitely beneficial to have something in the front. And then standing without equipment, we can always introduce for any caregiver, even if they have a standing frame. If we want them to participate in activities of daily living, like dressing or like changing a nappy or getting into the bath, or drying after bath. So just thinking about, even if this guy is leaning over his mom's arm, he's taking some weight on his legs, and just introducing that concept of standing without equipment can be beneficial to get a little bit of standing in throughout the day. Also, just thinking about transfer. So even if someone can't take all of their weight or have perfect standing, we can get them to do a small pivot in standing. And again, just having that concept of standing throughout the day. And then if we really have someone who is struggling to stand or have really poor feet, what can we do? What can we introduce? What principles of standing can we still introduce even with lying? So I think we spoke a lot about that when we spoke about the prone standing. Very similar concept that we can get here. So getting hips to stretch, weight bearing through arms, getting legs to stretch. And we can even lift a wedge a little bit more, as in this picture with some bricks or something, to have something in between prone, lying, and standing. So really just thinking of what the benefits are for that child's body and how we can implement that with what we have. And then we'll talk a little bit more about just being realistic of what we're asking someone to do. But if you as a therapist can't manage to do it, we can't really expect a caregiver or someone to do it. Or if you can do it once and then you're done, you can't really ask someone to implement that. So just, it sounds so basic, but just think about just trying in therapy first, letting someone practice. And like Sarah also mentioned, rather teaching a concept rather than this is how you do it. So teaching the principles and benefits of standing and how they can implement it. Okay, so how do we know someone is standing correctly? So this is also, again, something nice to maybe teach a caregiver or use with pictures or whatever. But to use the acronym STAND to remember what are the things we need to look for when someone is standing. So number one is shoes. We want those feet nice and supported. Usually the feet don't have great arches. They are collapsing medially. So we want to either have an AFO within a shoe, or at least an AFO, which is not always, I know that happens a lot, but we definitely want a shoe on, and not slippers, something with a nice rubber non-slip sole, and preferably something like in the picture that's more of a boot if they don't have AFOs. So yeah, just looking at nice proper shoes, if at all possible, because we are putting a lot of weight on the feet, and we want to protect them as well. So then T for tone, we will unpack that a little bit after this. Next slide. So just thinking about what we need to do to this body to help them get into standing, and each body might need something different. We'll look at that now. And then alignment. So as we are looking at a body outside of the standing frame, and how nicely Sarah has walked us through of just looking at alignment in lying, we know how they're going to sit, and we know how they're going to stand. And standing brings in even more gravity. So if someone's already collapsing and sitting, maybe to the one side, lateral collapse, or there's some rotation, we can expect the exact same thing, even worse, in standing. So we need to be prepared for that. But we are looking at alignment for good weight bearing. So we want the shoulders and the hips and the knees and the ankles to be in a straight line. That being said, sometimes we might want the shoulders a little bit forward, depending on what CP subtype and what that body is always doing. So not a rigid, like Gillian was saying, 90, 90, 90, but we want good alignment for good weight bearing through the feet, to get that benefit of increasing bone density and helping the hips. Right, we spoke about nipple height. So for our level 4 and 5 children, we would probably always go for nipple height. If the frame is lower, then they would need to use more of their trunk, and it would be more of an effort. So definitely want something that also supports the torso, and especially if there are any alignment issues, we want something there where we can add supports. So that's really important. So even if someone is standing with sandwich standing, or assisted standing in another way, even without a standing frame, we want to make sure that whatever the table is in front of them is at least at nipple height. And then we want to not just let someone stand there boring. It is such a nice way that activates a completely different sensory system. It is giving so much feedback to the body that usually the alertness and engagement is increased. So we really want to capitalize on that, and we want the child to do something while they are there. We don't want to make standing so difficult that they can't stand while doing, but we also don't want to get them doing so much that they can't stand. So classic, just the right challenge for them to do. But yeah, we can practice whatever. We can, even if it's not something to do with hand function, it can be communication, it can be just social engagement, vision work, anything that where they can participate. So just a nice way to remember of all the things we need to look at when someone is standing, that we make sure we have a good standing position. So just to recap a little bit about what Gillian said this in the beginning. I want to say this morning, it's not the same time everywhere, but with her presentation. So looking at what the child that you are working with in front of you needs, and not all stiff children are the same and not all dystonic children are the same, etc. So really looking at what is this body always doing, and not just taking someone and plonking them into standing, but preparing them for standing. So if they are stiff, we need to move and stretch and twist and massage to get them ready to stand, especially if they've maybe been sitting the whole day. We really want to also just open up and stretch the hips a little bit before we just plonk them in. If they are moving too much, we might need to bring in some stability. So pushing through their arms. You'll see on the middle picture that guy's more of a level 3, but just the concept of maybe first standing up in sandwich standing a little bit and pushing through his arms before he goes into the frame. Or someone who is pushing back, more of a dystonic pattern. What can we do to break that pattern, make them nice and relaxed before they go in? Think about, I'm saying go into a frame or go into the position. So what can we do to that body to help them relax? Like you saw the boy on Gillian's video where the mom helped him up into sitting. Can we have a nice flexed posture, a nice maybe an asymmetrical sitting of some kind to just help break that pattern, and slowly go into a standing position, telling them what you're going to do. And they might also need some massage, because often with dystonic kids, even though they're not stiff like a spastic child, they might have secondary stiffness, especially in their Achilles. So it's just a nice opportunity to get them nice and relaxed, and have them in a relaxed way when you're doing some massage and stretching for the muscles that are stiff. Or maybe you have a very floppy child and now you have to go from very floppy to standing upright, even though standing would help with that, getting into that position. It might be good to activate their trunk a little bit to increase their tone a little bit. So something like bouncing on a ball or moving around a little bit before we go into a more static position of standing. Or while we are standing, having something more active and more, giving more proprioceptive feedback, maybe through the arms, would be a good way to assist them in standing. Cool. Hope that makes sense. Right, so just some things that we should be aware of, just things that I've seen come up, and maybe I'm sure there are more. These are just the ones that I've seen a lot in practice with working with caregivers or with other therapists. So yeah, let's have a look at that. So number one, we definitely want to stand with shoes. You can see those little feet, especially with the socks on those. It's like a laminate plank. This frame is quite slippery, so it's very difficult to get a nice alignment. And then the plank at the back can, I'm sure, pushes on those heels. So I think it's a bit sore. So definitely shoes for better foot support and alignment. So let's look a little bit more at alignment. Yeah, these feet are quite stiff and contracted. So making a plan with filling in the gap, because this muscle is quite stiff, to get them completely flat is an option, but we definitely want some shoes. So this is, I would use with an orthotist guideline, and definitely let the child guide me if they have pain or not. But this is the type of foot that I would prefer to put in a prone stander, that we don't get so much weight and gravity dealing with that foot that's already in a compromised position. And then you'll see this little girl. You can just, if you can have X-ray eyes, imagine what this body looks like. Yeah, inside this box frame. It's probably like a zigzag. If you just look at the feet and where the knees are pointing. So if it's that easy to move their feet within a frame, I would look at, do we need to look at if we can get them a little bit more down in the frame? Do they need to have a little bit more weight bearing? Are they sort of wedged in and suspended in the air? And you can feel on the feet if one side is, if they're weight bearing more on one side than the other. So I would just feel with that. But also I would, just like what Sarah was saying with the lying, I would start at the hips and make sure my hips are aligned. So I would stick my hands in there. Or if you are standing with someone in a sandwich standing position, look at it or take a photo from behind and you can really see what the hips are doing. Get that right and then fix the feet. So we'll look more at what else you can do next slide, what we can do to support the feet a little bit more. And then this is also quite a classic not great alignment when standing. You'll see, if you can imagine, where the hips are about there and the knees, but our ankles are way behind. So it could be that he doesn't have the range, but that's why there's this little plank on most standing frames in different ways, like these foot things can move forward and backward. And it's for the purpose of getting them to be a little bit more forward, that the ankles are under the knees so that we have a nice alignment. So you can see there the before, and then just moving the feet a little bit forward. So just having better alignment. But he does need to have the range. Okay. So this is an option for this goal where the feet are flying all over. So using a towel or a ball or something soft or a sponge or another shoe, but just helping the feet with the alignment. But the key thing is to look what the hips are doing. And if your hips are aligned and the top is aligned and everything is looking good, then you add your foot support if they still need it. So we want to look at alignment from behind, but we also want to look at alignment from the side and obviously further up with the body as well. Okay, and then just making sure someone has enough support. So this little girl is quite a floppy girl with quite low engagement. So really needed a lot of input to get her to just participate. But you'll see here she's got support on the side, but I covered her eyes, but where those little fake eyes are, that's where her eyes are looking. So even though there's all the stimulation in the front, she can't get there because she doesn't have enough support for her head. So just looking at what this body needs, she needs to be a little bit more forward to help her engage with her eyes. And then as her eyes engage, her body engages a little bit more. So just being aware of what are we asking someone's body to do, and what are they able to do. Just check time. Okay, I hope that makes sense. So my last story that I think we've mentioned, I mentioned in the beginning, and I think Gillian and Sarah have mentioned, but just how do we give this over to a caregiver? How do we get someone's buy-in to do this task? So I think definitely having realistic expectations. We are not going from zero to hero. We are building up for a child and for a caregiver to tolerate. And I think a big thing that we need to start with is understanding what is a child and a caregiver's daily routine. How many other children does the caregiver need to look after? What are her daily tasks that she has to do at home, for instance? And listening how they do things at home can also give you a guide to help them think how they can incorporate standing as a daily routine. And it doesn't have to be you having a lecture with them. This is how we're going to implement standing. This can be a conversation, and this can be a question to them. Once the principles are discussed, how do you think you can incorporate standing? So let it come from them as well. That it's not a I've been told to do this, but that they take some ownership of it, but also making it very realistic for them, so that it becomes part of life, so that it's not an exercise or another thing that they have to do. And if it's only that I stand to take my pants off for now, then that's a great start. It's standing that they've never had. Yeah, so just also allowing time and factoring in time. I don't have stats like Sarah that said it will take 3 months for a child to get used to the lying position, but I can imagine very similar would be for standing, because it's something that they don't often do and they are not used to, just because of them being level 4 and 5 GMFCS. So allowing time, allowing a caregiver to practice and settling into that routine. I think just having some grace and understanding in that part will go further. And then, like I said in the beginning, if someone understands why we are doing this and approach it, that it's not a lecture, that it's not just, oh, it's this and this and this is the benefits and this is why you need to do it. But having a discussion of what can happen over time, having a discussion of what the benefits of standing would be, and thinking together how we can implement that would probably go much further. And to let them feel on their own bodies. So have them in sandwich standing. You might be short or you have to configure it, but let them feel the concept of sandwich standing and how it holds them, and how long they can hold it or whatever. Let them feel it with their bodies before they do it with their children. And when they do it, maybe take a photo, even if it's just on your phone, and showing it to them and let them unpack and say, oh, but actually they're not that straight. Oh, maybe the foot must be there. So asking them, what do you think of this position? Does it work or doesn't it work? So not just coming from I know everything kind of point of view, but really having a brainstorm and a problem solving, because each child is different, and what works, like I say, not all the tonics, for example, are the same, and what works for one doesn't work for the other. So taking those principles that Gillian gave to us in the beginning, we can implement that with Sarah's lying as well. What can we do for this body? What does it need to be able to relax or to be loose? And we can do that the same with standing. So using that as your starting point to help someone help their child to stand. Cool. And then I just want to share with you some resources. So I know Daniel will probably mention more tomorrow, but they really have nice equipment and strategies, and they are willing to assist wherever they can in terms of problem solving. Like what do you have at your disposal and how can you use it? And then I found a very nice Instagram page, Adaptive Life Hacks, that you can go have a look at. There's a few cool things on there, but related to standing, they've got an adaptive prone stander. they've got some PVC pipe walking support that can, and standing support, maybe a little bit more for a level 3 child, but you can go have a look. They've got some seats, PVC seating options, and then they also have another type of design for a box stand that you can do with plywood or with cardboard, and a lot of other quite nice things to go have a look at. So definitely check them out. And then there is a blog of the mama that makes that has a pattern for a keystone splint. She doesn't call it a keystone splint, but the concept is the same, which I thought was quite nice. So yeah, that is my whole story. I hope that you learned something about standing today, or made you think of standing in a bit of a different way and how to approach it. And yeah, if you have any questions, we can, we've got some time to do that.
Carby, thanks for that. Please do post any questions that you have while we have Carby. We still have a few minutes. And I just want to say thank you to you all for your time that you have given us today. I hope you found it helpful. There was one comment that I have just made a response to, and it was a very good question around what about the position when a child is carried on a caregiver's back. And I will tell you that I spent many years thinking that I could solve that problem, but in fact you can't. There's no helpful, good way that a child can be carried on a caregiver's back for many reasons. It's not the best position or most helpful position for a child. There's a lot of friction, the trunk is quite sagging, the head's turned to one side, but you have to recognize that the caregiver may not have a choice. So I think that's the first thing. You can't, I have to ask, why is the caregiver carrying the child on her back? And firstly, understand if there's anything that I can do to change that, so that she doesn't have to do it. Obviously, if the caregiver has got a very wide back, what worries me enormously is how much those hips have to be abducted. And I think that's where I certainly draw the line. If abducting the hips to get the legs around the caregiver's back is causing the child pain, that is an absolute no-no. I would stop that immediately. There's no ways that we should be causing any child pain at all.